Dear respected ladies and gentlemen, Assalamu alaikum and good day for all of you from around the world. On behalf of Dr. Ahmed Laweni, the leader of IVPN Journal Club, Leicester, thank you for joining us tonight as we are gathering more than 250 delegates from 15 different countries. Our mission in IVPN to share the latest published evidence, learn from high caliber and world-class pharmacotherapy experts in analyzing primary literature, read by context, ultimately to optimize the clinical practice. Tonight, our esteemed, renowned experts from the United States and Dr. Lulwa will be sharing in-depth discussion about the practice and clinical peers on dosing on monitoring vancomycin using novel strategy. Also, we will learn to enjoy the critical evaluation of one of the landmark studies that led to the guide of vancomycin dosing strategies. Additionally, what will make this session even more exciting and influential is to having Dr. Sireen, renowned moderator to tonight's webinar. Dr. Sireen Shukr is a PharmD graduate from the University of Toledo College of Pharmacy in 2000. She got her residency program BGY1 in Pro Medical Toledo Hospital. Is a PharmD of Toledo College of Pharmacy Toledo in 2013. She got her residency BGY1 at Pro Medica Toledo Hospital and Toledo Children's Inpatient Care setting. She had a wide experience in retail ambulatory care, where she managed anticoagulation clinic at the University of Toledo Medical, and currently she's practicing at Bon Secours Mercy Health Medical Center as a medicine clinical pharmacist. She assists in providing clinical services as a part of multidisciplinary team. She's a pharmacy student and resident. Additionally, she's passionate about the patient education transition of care to ensure safe and effective continuity of care and reduce readmission. Sireen is also the leader of IVPN Patient Support, Leicester, IVPN Broadcast, and as well as counseling competition. Her interest in research is patient education, program development, and management, and student development. With that, Sireen, the screen is yours for moderating. Thank you.
Thank you, Shahama, for your introduction. Thank you, everyone. Thank you, Lulua, and thank you, Kwan, for accepting my invitation for today's discussion. And today we're going to be starting with Dr. Kwan Sturgill. It's an honor to introduce Kwan. She will be starting our discussion today. And Dr. Kwan, she received her Bachelor's of Science in Pharmaceutical Science from the University of Toledo, in 2019, and she also graduated from her PharmD in May 2021. I'm sorry, right? Is that correct? Yes. So from the University of Toledo, and she's currently as well our resident at St. Vincent Medical Center. And she's currently, her interest is hematology and oncology. And she's currently served as on the Resident Advisory Committee Chair for the Ohio College of Clinical Pharmacy of 2021-2022. And Kwan, she will be starting our discussion today in talking about the landmark study that led to one of the updates in the vancomycin practice. So go ahead, the floor is yours.
Thank you so much for that introduction. Let me go ahead and share my screen. Okay, and everyone's able to see my full screen?
Yes.
Yes.
Great, thank you. All right, hello everyone. My name is Juan Sturgill. As Serene introduced me, I am the PGY1 Pharmacy Practice Resident at Mercy Health St. Vincent Medical Center in Toledo, Ohio. First off, I want to thank you so much for the opportunity to present today. It truly is an honor. And my journal club presentation will be focused on evaluating vancomycin trough versus AUC dosing. Here I have provided a QR code which you're able to scan, and it will pull up a copy of the journal club article in case you want to follow along or reference. And the title of the article is a prospective trial on the use of trough concentration versus area under the curve to determine therapeutic vancomycin dosing. A little bit of background. So vancomycin is used to treat gram-positive infections, including methicillin-resistant Staph aureus, also known as MRSA, and beta-lactam-resistant Streptococcus and Enterococcus species. Now, due to an increasing amount of antibiotic-resistant organisms, there is increased morbidity and mortality. Therefore, it is vital that vancomycin is used and dosed appropriately for hospitalized patients. And ways to optimize and maximize the efficacy of vancomycin, as well as minimize toxicity, most importantly, nephrotoxicity, includes ensuring appropriate dosing, appropriate use and indication, and then also monitoring. In 2009, the American Society of Health System Pharmacists, the Infectious Diseases Society of America, and the Society of Infectious Disease Pharmacists published specific guidelines about vancomycin dosage and monitoring. They supported the use of trough-guided dosing, and then these guidelines stated that trough serum concentrations are the most accurate and practical method of monitoring effectiveness. They also recommended obtaining trough concentrations just before the fourth dose at steady state conditions. And then the trough levels that they advocated for were between 15 and 20. And that was recommended to improve penetration, increase the probability of optimal target serum concentrations, and improve clinical outcomes of complicated infections such as osteomyelitis, bacteremia, pneumonia, and endocarditis. The guidelines also stated that maintaining troughs in this range should achieve an AUC to MIC ratio greater than 400 for most patients if the MIC is less than 1. And then in 2020, a revised consensus guideline and review by ASHP, IDSA, the Pediatric Infectious Diseases Society, and then again, SIDP, they came out with a revision and then they promoted AUC guided dosing. So these guidelines confirmed that a target of AUC to MIC ratio of 400 to 600 should be advocated to achieve clinical efficacy while improving patient safety. The guidelines also stated that trough only monitoring with a 15 to 20 target is no longer recommended for serious MRSA infections. And then using AUC guided dosing maximizes efficacy and minimizes the likelihood of acute kidney injury. And they also stated that an AUC less than 400 potentiates the emergence of resistance. And then the guidelines go on to say that there's two ways to calculate AUC. The first is using first order pharmacokinetic equations, requiring 2 serum concentrations, or using a Bayesian software program. Now, there's a few reasons why this study is important. So since 2009, a number of publications have evaluated the clinical efficacy and toxicity of vancomycin use in MRSA infections. And then recent studies have highlighted the importance of generating valid estimates of AUC values using Bayesian modeling techniques. And then finally, these software dosing programs are more readily available than they were in the past and can be used in real time to identify optimal vancomycin dosing regimens that achieve that AUC target. Next, I'll be moving on to a review of the Journal Club article. And then a little bit about the main author. Dr. Michael Neely is the director of the Laboratory of Applied Pharmacokinetics and Bioinformatics, which has been using pharmacokinetic modeling techniques and dose optimization for individual patients for over 35 years. He's also a professor of pediatrics, and he's a clinical scholar at the University of Southern California, and he's also the chief of infectious diseases at the Children's Hospital of Los Angeles. For conflicts of interest, this work was supported by the National Institutes of Health to MNN, and MNN was involved with a few other organizations to develop the best dose software, which was used in the study. They also received a few grants, which are listed below. And then for the study objectives, the primary hypothesis was that AUC-guided treatment is more likely to be therapeutic than trough concentration-guided treatments. The authors hypothesized that targeting troughs greater than 15 would actually overdose many adults as compared to targeting an AUC. And then for the secondary hypothesis of the study, vancomycin dosing, concentrations, and nephrotoxicity will be lower with using Bayesian estimation-assisted AUC guided dosing. And then overall, the authors expected the efficacy of AUC guided dosing to be the same or better than that seen with trough concentration guided dosing. And then here I have a little bit about best dose software, which is what was used in the study. So how it works is that best dose combines the population model with the data from each individual patient to comprise the most likely probability distribution of support points for the patients. And each support point consists of a set of vancomycin pharmacokinetic parameter values, such as volume of distribution and the probability of that set. So as more vancomycin concentrations are gathered over time for an individual, the model becomes increasingly specific to that patient. And then from this model, for any given dosage regimen, the predicted concentration of vancomycin may be calculated by the software at any moment in time. For the study design, this was a 3-year prospective serial cohort study of vancomycin dosing, plasma concentrations, and outcomes. It was performed at the Los Angeles County University of Southern California Medical Center, which was a 600-bed tertiary care university-affiliated county hospital. For methods, first-year subjects served as controls with vancomycin dosing, concentration monitoring, and management according to decisions of the treating physician and clinical pharmacy staff. Troughs of 10 to 20 infection dependent were targeted, and this data was used to estimate daily vancomycin AUCs for each patient using the best dose Bayesian software. And in year 2, they target vancomycin daily AUCs greater than or equal to 400 with a max AUC of 800, and controlled vancomycin dosing using the multiple model Bayesian adaptive control algorithm in best dose. They continued the standard practice of attempting to obtain trough concentrations, but did not target or control these concentrations. And then finally, in year 3, they continued to use best dose for AUC targeting. In addition to calculating the optimal dose, they used the multiple model optimal sampling function to calculate the most informative date and time to measure the next vancomycin concentration for each patient. Patients were eligible for enrollment if they were greater than or equal to 18 years old and had been prescribed IV vancomycin therapy with at least one measured concentration indicating that therapy would be continued beyond 48 hours. Patients were excluded if they were on any form of renal replacement therapy or their expected survival was less than 72 hours. And then looking at the outcomes, the primary outcome included the timing and value of troths, proportion of troths within goal, and proportion within the AUC to MIC ratio. For secondary outcomes, that included starting and average daily doses, duration of therapy, length of hospitalization, number of blood samples, and therapeutic outcomes such as therapeutic failure or death. And the study defined treatment failure as the need to add or change therapy to another drug with a similar spectrum of activity. So that could be something like daptomycin or linezolid. And finally, the study looked at safety, the development of nephrotoxicity. And the study defined nephrotoxicity as an increase in serum creatinine greater than or equal to 0.5 or greater than or equal to 50% from baseline, and it needed to be confirmed on 2 consecutive measurements and more highly attributable to vancomycin than to any other cause, and that was determined by the primary team. Moving on to the results of the study. There were 252 adults that were enrolled from December 2012 to June 2016. And there were 75 patients in year 1, which was the control, 88 patients in year 2, and that was using that multiple model best dose, and then 89 patients in year 3, that was the multiple model optimal best dose. As for baseline characteristics, patient characteristics were similar except for ethnicity, which was based on self-reporting. And then the mean age was around 48 years old, about 67% were male, and the mean weight was 81 kilograms. Baseline renal function data, and that was quantified using the Cockcroft-Gault estimator, was similar across the years. And then the most common indication for vancomycin was skin and soft tissue infections. That made up about 46% of the infections. Of note, significantly more patients had pneumonia and bacteremia in year 3 than in the prior 2 years. And then from this table, the isolated organisms differed, with the most common being S. aureus. However, there was no significant trend in the variety of species by year, and that p-value was 0.45. Also, the majority, 88% of MRSA isolates had a vancomycin MIC less than or equal to 1, and then all were vancomycin susceptible with an MIC less than or equal to 2. As for the primary outcomes, of the trough concentrations in each year, 28%, 13%, and 15% were therapeutic overall, and an overall rate of 28% therapeutic trough concentrations is consistent with this trial's pre-study survey, finding that 30% trough concentrations were therapeutic. Now, in contrast, 75%, 63%, and 73% of the AUC-guided therapies were therapeutic. In years 2 and 3, AUCs were targeted instead of troughs. So hence, the low rates of therapeutic trough concentrations are not surprising. And then over the entire study, 19% of trough concentrations versus 70% of associated AUCs were therapeutic. That p-value is significant, less than 0.0001. And then 31% of AUCs greater than or equal to 400 were associated with a trough less than 10, and 68% were associated with a trough less than 15. For secondary outcomes, the starting and average daily doses and length of hospitalization did not differ significantly from year to year. However, the length of vancomycin therapy was significantly shorter in years 2 and 3 than in year 1. And then the mean number of blood samples were lower in years 2 and 3. So having a smaller number of blood samples reflects a more efficient therapeutic management with Bayesian control. And then the median concentration in samples that were obtained within the trough concentration window after enrollment also dropped significantly after year 1. And then finally, for safety, here for the occurrence of nephrotoxicity, you can see that in year 1, 6 patients or 8% developed nephrotoxicity. No patients in year 2 developed nephrotoxicity, and then 2 patients in year 3 or 2% developed nephrotoxicity. And then 2 of the 6 subjects in year 1 stopped therapy due to toxicity versus none in years 2 and 3. The median first measured vancomycin concentration was 15.7 in those who developed nephrotoxicity and was 8.7 in those who did not. And the median initial vancomycin AUC was 625 in those who developed nephrotoxicity and 423 in those who did not. And then finally, looking at median length of stay, it was 20 days for those who developed nephrotoxicity versus 6 days for those who did not. On the basis of a preliminary survey of 20 patients, approximately 30% of appropriately timed vancomycin trough concentrations were noted to be therapeutic prior to the study. And to demonstrate that a 50% proportion of therapeutic AUCs would be significantly higher than 30% with an alpha or type 1 error rate of 5% and achieving a power of 80% or a 20% type 2 error rate in any given year, approximately 90 patients were required in each group. All statistical tests were two-tailed and a p-value of less than 0.05 denoted significance. And then looking at the specific types of statistical tests that were used, for non-normal continuous data, a Mann-Whitney test was used. For normal continuous data, students' t-test. For a multivariate analysis of non-normal data, the Kruskal-Wallis test was used. For normal data analysis of variance or linear regression. And then for categorical data, Fisher's exact test or chi-square test was used. And this report represents the largest prospective study of Bayesian estimation-controlled AUC-guided dosing in adults published thus far. The primary hypothesis was supported by more patients achieving therapeutic success when targeting an AUC to MIC ratio greater than or equal to 400 as compared to targeting troughs. And then finally, using trough concentration targets generally results in unnecessarily high levels of vancomycin dosing, increasing the risk of nephrotoxicity. And this is consistent with many observations reported in the literature. And this increase in renal injury has been associated with markedly longer hospital stays, which can increase costs by thousands of dollars. As for efficacy, there was no compromise in the clinical outcomes of infections treated with vancomycin, despite having lower average trough concentrations than recommended. As for strengths of the study, it was a prospective design, and because of the study design, since exposures are assessed before outcomes occur, they are less prone to bias. There was also a preservation of efficacy, a diverse patient population, and real-world application. So overall, the lack of any obvious reduced efficacy using vancomycin AUC targeting for a prospectively studied diverse patient population is encouraging. For limitations, this was a small sample size and performed at a single center. This study was also not designed or powered to evaluate treatment efficacy of trough-guided versus AUC-guided vancomycin dosing for defined infections with MRSA. And actually only 10% of the study population had microbiologically proven MRSA infections. Another limitation is that the diversity of infections dilutes infection-specific validity of concentration targets used. And then finally, there was a relatively short duration of vancomycin therapy, and that's likely a reflection of a lot of patients had skin and soft tissue infections. And those are typically treated with vancomycin for shorter durations before therapy is de-escalated to an oral agent. And the author concluded that trial concentration guided dosing should be replaced by AUC guided dosing, and preferably with a Bayesian estimation assisted control. They also listed many benefits of using AUC dosing, including reduced nephrotoxicity, fewer blood samples, a shorter duration of therapy, lower doses overall than current recommendations, tighter control of vancomycin exposures, and all without an obvious compromise in clinical efficacy. As for impact on clinical practice, AUC guided dosing should be considered over trial concentration guided dosing. If available, Bayesian software programs should be used to generate accurate and reliable estimates of AUC values with trough-only pharmacokinetic sampling. And then finally, there is the potential for substantial cost savings at hospitals that use vancomycin extensively. And here I have displayed the references that I used for this presentation. And that concludes my journal club presentation.
Wow, Kwan, very, very nice. Great work, great job. I think I've learned so much. Thank you so much for your hard work. I bet everybody had a lot of questions, but we're gonna leave all the questions till the end of the presentations. And we're gonna move next to Dr. Maktabi Lulua. She will be as well taking us into more in-depth discussion about all the details about the AUC, so we can get smarter and stronger about AUC and Bayesian, and getting more comfortable using the vancomycin dosing with the new guidelines updates. So Dr. Lulua, if you're ready, we're ready to hear you.
All right, I'm going to share my screen. All right, looking good for everybody?
Yes, I see it.
Okay, well, thank you, Sirin, for having me today and including me on your discussion with Juan. It's very nice to see everyone.
I forgot to introduce you to give everybody a small bio. I was so excited to about your presentation, but I want everybody to know who Lulua is. Lulua Maktabi, in 2014, she moved from Aleppo, Syria to the United States as a transfer student to continue her pharmacy education. And she earned her Doctor of Pharmacy degree from the University of Toledo in Ohio and completed her PGY1 as well at Mercy St. Vincent Medical Center. So she's a graduate as well from our program. And she has a keen interest in teaching and recently joined the University of Toledo as a clinical assistant professor in pharmacy practice. And she's currently teaching inpatient skills labs and delivering lectures in therapeutics and pharmacotherapeutics. And she also practices in inpatient settings and rounds with the internal medicine team as well. And now the floor is yours, and looking forward.
Awesome. Thank you so much, Sirin.
Thank you.
So today, as Sirin mentioned, so now this part of the presentation, I'm kind of going to take you into the details, talking a little bit more in depth about the kinetics, the math, the equations, and still, of course, continuing the discussion on how to optimize vancomycin dosing using AUC. So my learning objectives for my part of the presentation, I always do this with students, so I'm getting used to the habit of this. So we're going to review the pharmacodynamic and toxicodynamic principles of vancomycin, discuss the current evidence, of course, and guideline recommendations, list the benefits of vancomycin therapeutic drug monitoring by area under the concentration time curve, and then we'll describe methods of performing AUC drug monitoring. So here's our little overview. Our pharmacy team is going to stop first. We're going to talk or review the guideline recommendations and trough versus AUC. So a little refresher on vancomycin kinetics. As we know, vancomycin is a bactericidal antibiotic from the glycopeptide class. It exhibits concentration-independent killing, which means that effective killing depends on time above the MIC. And so troughs, historically, we monitor troughs for efficacy. And typically, we like to see that general trough goal range of 10 to 20. And then with your more serious infections, we see that higher target trough of 15 to 20. However, current data suggests that AUC to MIC is the actual best predictor for outcomes for this time-dependent antibiotic. And in vitro and in vivo bactericidal activity is achieved when the vancomycin AUC to MIC ratio approximates or exceeds 400. And we'll talk about all of those points in depth. And so it's interesting that if an antibiotic has both concentration and time-dependent effects, you may observe killing that is associated with that free drug area under the curve to MIC ratio. So doing some visual learning here. So looking at your concentration versus time curve, reminding you of all the different antibiotic classes and what they relate to in terms of their kinetics. So here you have your Cmax, and that reminds you of the antibiotics that are concentration dependent. So the higher the concentration, the better efficacy. And that reminds you probably of antibiotic classes such as aminoglycosides, fluoroquinolones, the agent daptomycin. And then down here, you have your minimum inhibitory concentration or your MIC. And that also reminds you of the antibiotics that are time dependent. So as long as they're above the MIC, then you see that efficacy with these classes of antibiotics, such as beta-lactams, carbapenems, and vancomycin, as we mentioned. Now, this area in the middle is the area under the curve that we've been talking about, right? And so this is when you have an antibiotic that is both concentration dependent and has time dependence with that as well. And vancomycin also fits into this category. And that's really where the discussion of this different type of monitoring comes about. So to simplify a little bit what AUC really means, it's typically, when we think about it, it's the exposure of the organism to the antibiotic. So we're trying to maximize our exposure and measure the amount of time that the drug is, the organism is exposed to the drug in the body. Versus your MIC, which like we said, is your minimum inhibitory concentration. So revisiting the guidelines that Kwan also reviewed for us as well. So here I just kind of wanted to see the difference between our 2009 guidelines and how different those recommendations were from the 2020. So in 2009, as we know at the time, we eliminated routine monitoring of serum peak concentrations. And this is where trough concentrations of 15 to 20 were promoted for complicated Staph aureus infections to achieve that AUC of 400 or greater when your MIC is 1 or less. And here we were looking at single trough concentrations before the 4th dose, so you're still waiting for steady state to start that monitoring. And then in 2020, we see these new recommendations about this AUC of 400 to 600 that's recommended for serious MRSA infections, of course, assuming that MIC of 1. And how can we do that? We're going to talk about this also later on in the presentation. So the recommendations here are to use first order pharmacokinetic equations requiring 2 concentrations from your patient or Bayesian software as well. And here the recommendation was shifting away from that 15 to 20 target, and it is no longer recommended for serious MRSA infections. So I was interested in how the 2009 recommendations came about. So let's take a look a little bit and see how is there truly a disconnection, or what were those AUC values there all along, but we're just reintroducing them back into practice. So where did the initial recommendations come from with those higher troughs? So at the time we were seeing, or in our institutions, they were seeing an MIC creep or a potential progression of resistance with vancomycin. So underdosing of vancomycin led to poor outcomes and treatment failures. And so those higher troughs were proposed as a way to ensure patients achieve that ideal 24-hour AUC to MIC. And so with aggressive dosing, we were able to improve efficacy in serious MRSA infections. However, we were seeing increased rates of nephrotoxicity, which makes sense because we're exposing the patients to more vancomycin and with higher doses potentially. So vancomycin trough concentrations have historically been used as a surrogate marker to estimate AUC to MIC. So that ratio is not really a new concept. It's just that at the time, it was thought that AUC was difficult to estimate in the clinical setting, and because it requires that software and different calculations. So it was basically just decided or proposed that as long as you maintain that trough concentration of 15 or greater, you should mathematically be in that AUC of more than 400 in most patients. So that's really where the recommendation came from. It's not that AUC wasn't a concept back then, it still was. It's just that we were just proposing that they should correlate. Those two concepts should correlate. So now we're going to dig deeper into that question. So that relationship between vancomycin trough and AUC, is it really reliable? And if it is it reliable all the time for all of your patients? And what's interesting is that many studies actually found that trough guided dosing may not be as well correlated with AUC to MIC. And this, as we're talking about, can lead to unnecessary antibiotic exposure and nephrotoxicity. So here I have a couple of studies that we can kind of touch on. One by Neely and colleagues, which was a large model of pharmacokinetic data. And what they wanted to do here was explore that assumption that troughs were appropriate markers for AUC. And they included 47 adults and with various levels of renal function. And they had around 570 vancomycin concentrations. And so with P-metrics, the authors observed that trough-only data and underestimated the true AUC by 23%. And that estimates suggest more than 50% of adults with an AUC of more than 400 actually have a trough of less than 15, which is very interesting. Another study by Lodi's and colleagues was a retrospective cohort. And what they wanted to do was look at vancomycin exposure variables, so your trough versus your AUC, and how that would affect outcomes. Here, they included 123 hospitalized adult non-dialysis patients with MRSA bloodstream infections. And what they found was that comparing vancomycin exposure and treatment outcomes on days 1 and 2 of therapy with achieving that therapeutic AUC to MIC ratio was independently associated with treatment success. And then our last study that we're going to touch on here was a meta-analysis of 14 observational cohort studies. And what this study wanted to look at was determine the strength of those studies that were recommending the higher trough levels. So here there are around 1,680 patients who received standard dosing of vancomycin for Staph aureus bacteremia. Again, the goal was that high trough of 15 to 20. And what they found was that higher trough levels were not associated with reduced treatment failure, reduced persistent bacteremia, or mortality. And that higher AUC to MIC values were actually associated with treatment success. So how come? How is it that sometimes you can have a trough of less than 15 and your patient can still be therapeutic? So here we have some visual representation. This is a study that included a Monte Carlo simulation of 5,000 subjects that were basically, we're assuming that they were administered a vancomycin regimen of 1 gram every hour. And so the purpose of this model was really to predict the probability of different outcomes when you have random variables as the intervention. So we're trying to see how there is or isn't a correlation between that trough and AUC. What they found was that there is a high degree of inter-individual variability between a measured trough concentration and the actual AUC value. So if I direct your attention to this nice red box here, looking at our AUC versus your trough concentration, as you can see, we are below that 15, so the lower of that target range. We are below 15, but you still have a lot of data points that are above the efficacious 400 AUC value. So that's very interesting. You can see that there's a lot. There are some, of course, that are still not therapeutic, but there are a lot that are above that 400 range. And so here they concluded that we really can't rely on that 15 to 20 trough goal concentration to achieve an AUC to MIC of more than 400, because these patients, or based on the simulation, you can have some data points that even though they're below 15, your AUC is still therapeutic. So shifting to another idea or concept that we're going to talk about, let's look at the data points that are between 15 and 20, right, which is our target range for serious infections. Now here, as you can see, all of your data points are definitely going to be above 400 because the trough concentration is the lowest concentration that we observe in a dosing interval. But then if you take a look at the high variability in the upper range, so you see levels beyond 600, 800, going into 1200, and those are the levels that can be nephrotoxic to patients. And so this is where we're going to delve deeper into the benefits of switching to AUC monitoring. So of course, we're talking a lot about AUC, right? But really it's an AUC to MIC ratio. So just touching a little bit on MIC, based on the recommendations, we're assuming that our infection is caused by MRSA with a vancomycin MIC of 1. And really majority of MRSA isolates in most institutions is 1 or less. When measured by your non-automated broth microdilution, which is typically done in the laboratory. And measurement of that MIC is imprecise, so there is an acceptable variation in the results. And so usually it's attributed to potentially measurement errors and things like that. But the concept is there data in the literature telling us what to do with that AUC target when the MIC is above 1, or let's say 2? And in reality, when we're thinking about testing for MIC, results are typically not available within that first 72 hours of culture collection. And we know with treating our very serious infections, first 48 hours are the most important in determining outcomes. And so the literature really points to, we don't have to test for an MIC. We're really going to be treating the patient clinically based on the fact that MIC is assumed to be 1. And if you find that your patient is not responding, they're not getting better, obviously at that point, we would just switch to an alternative agent. So there's really no recommendations as to what we would do or what target AUC to MIC ratio should we have if the MIC is above 1. So our next stop is the proposed benefits of AUC as promised. So again, going back to the idea of nephrotoxicity and highlighting that 15 to 20 target range that we were talking about, which is the higher trough goal range. So the literature suggests that risk of vancomycin associated AKI increases with a trough concentration maintained above 15 to 20. And when you think about your AUC as well, the risk of AKI also increases along that continuum, especially when it exceeds 650 to 1300, which is what we were talking about. Although all your data points here are definitely therapeutic, but there's a big degree of variability in those upper values, and you're potentially putting those patients at risk for nephrotoxicity. And a lot of the literature points to 700 as your really maximum AUC beyond the 400 to 600 range. 700 is probably the cap that I've noticed in most of the literature. So looking at a couple studies that highlight this benefit of AUC monitoring. So many studies have found that using vancomycin AUC monitoring strategy reduces that nephrotoxicity. So this first study was a multi-center retrospective cohort. They included 323 adult patients receiving IV vancomycin. And what they found was that nephrotoxicity was significantly higher in patients with those AUCs that were beyond 677. So directing your attention to the AUC, the 24-hour one specifically. And when you look at the trough levels that were also associated with nephrotoxicity, those were also above 18.8. So still therapeutic in that higher range, but that's where they were starting to see significant nephrotoxicity. Another study here, which was an experiment conducted at Detroit Medical Center. This one retrospectively evaluated incidence of nephrotoxicity between patients, and they looked at that trough group versus your AUC group. This study included 1,280 adult patients, again, receiving IV vancomycin for a suspected serious infection. So what they found here was that AUC-guided dosing was independently associated with lower nephrotoxicity by both logistic regression and Cox proportional hazards regression. So it was a 50% odds ratio reduction in those patients that were monitored through AUC. And another monitoring parameter or outcome that they were looking at was also vancomycin doses and AUC values. And AUC guided dosing was also associated with lower total daily doses, values, and trough concentrations, which makes sense. You're not exposing those patients to the same regimens, probably not the same number of doses, and so on. But something to note with this study, and probably with a lot of the other studies that report on the reduction of nephrotoxicity, in this study and at this medical center, they noted that they do target those higher troughs frequently. They do see a lot of serious infections. They do dose vancomycin pretty aggressively. And so that's why they saw such a profound reduction in nephrotoxicity. So if you work at an institution where you don't typically target those high trough levels, you're not using those aggressive doses as much, you're not seeing those serious or aggressive infections as much, switching to AUC, you might not see that big reduction in nephrotoxicity versus other institutions, but you would still have those reduced exposures for the patients, and then efficacy is still maintained as well. And then this was the study that Kwan walked us through as well. I included this since it was a good study to include for the data on this topic. And so like Kwan mentioned, with this study, ultimately, they found that only 19% of trough concentrations were therapeutic in those patients versus 70% of those with AUC monitoring. And that the first time around, patients, if they had been monitored using AUC, they would have been therapeutic 75% of the time versus only 28% of the time when they were monitored with troughs. All right, so we talked about AUC and how great it is to potentially monitor our patients using AUC. So how do we do the math? How can we apply this in our institutions? So there are two methods, and this follows with the guideline recommendations as well. So you have your first order pharmacokinetic equations, and then you also have your Bayesian method. So your first order kinetics involves two levels. So you're still going to be retrieving two levels from your patients, potentially a peak and a trough around the same dose. However, it does still have to be at steady state. And so you would potentially do your peak after your fourth dose and then your trough before your fifth, basically around the same dose after steady state. And here, typically with first order kinetics, it is more simple, as we'll see with Bayesian, the Bayesian method. So typically institutions can use a calculator, like an online calculator embedded in their electronic medical record, as well as an Excel sheet that a lot of pharmacists can use for efficiency as well. Versus our Bayesian method, all you need is a single level. Now, a lot of the literature states that two are preferred, but you really can conduct it with one level. And steady state is not required. And you can collect that level as soon as the first 24 to 48 hours. However, Bayesian math cannot be done by hand. It really does require dedicated software. And we're going to talk a little bit about that as well. So thinking of first order kinetics, every time I think of the trapezoidal method, I think of my first year and second year in pharmacy school, and these are all the formulations and equations that pop up into my head. So thinking of all those steps that you kind of have to fill out to get to your AUC, but really it's more simple than that. So walking through a little refresher on first order kinetics. So typically you start by calculating your patient-specific KE. So here, as you can see on the graph, you need your peak and your trough, so your C1 and your C2. However, we do want that true peak and our true trough. So we're going to use our back calculations to find those, as those are the values that you would plug in into your AUC equation. And it's really pretty much as simple as that. A lot of institutions do use this method. I know I attended a lecture by a pharmacist who works with the Stanford University affiliated hospitals in California, and they use this method following an Excel sheet for the pharmacists. So what are the advantages of first order kinetics? You do use patient-specific parameters. It's simple and familiar to most clinicians, and it does rely on fewer assumptions compared to the Bayesian method, which we'll talk about. And looking at your total daily dose, it can be revised based on proportional changes, of course, assuming stable conditions. So it can be tweaked to adjust based on your patient. However, some of the downsides or disadvantages, you still need those more frequent levels and blood draws. It's preferred that concentrations are collected in your steady state, and it's not as adaptive as the Bayesian approach. It only provides you a snapshot of the AUC and will need adjustment if a physiological change occurs. And lastly, it's difficult to estimate a 24-hour AUC in patients who are receiving multiple dosing regimens. However, you will find recommendations on how to do that with first order kinetics. It's just not as easy as we'll see with the Bayesian software. So that brings us to Bayesian estimated AUC, which is based on Bayes' theorem. The theory states that one can describe the probability of an event based upon prior knowledge or conditions that might be related to the event. And so here your AUC is being estimated based on combining your traditional pharmacokinetic methods as well as advanced statistical tools. And here I just wanted to point out, I was looking through PubMed and I found this really old article, well, not really old, but like an older article. And as I saw that it was published or accepted in 1990. So the concept of AUC and the Bayesian method, again, is not really new. It's just something that we are being reintroduced to with the updated guidelines. So here, this is basically the description of Bayesian estimated AUC in the guidelines. I'm going to simplify that upper portion here for you. So basically you have your Bayesian prior, you have the likelihood that your patient is going to respond similar to your population kinetics. And then you take that Bayesian prior or your probability, your likelihood, and you adjust it based on patient-specific data, which is your vancomycin levels or the levels that you obtain from your patient. And based on that data, now you have your revised probability and you have your AUC estimation for that patient. So basically you're taking that, that probability, adjusting it based on your patient, and then your Bayesian software basically gives you a probability that it's predicting that your patient will respond to in the future. So again, what are some of the advantages of Bayesian estimated AUC? You can collect concentrations within that first 24 to 48 hours rather than waiting till steady state, so it's quite flexible. Single levels may be sufficient, and you can account for any pathophysiological changes, so it's quite adaptive. However, your calculations cannot be done by hand. There are different calculators and softwares that are used, and those use different models depending on what kinetic studies and populations were included. And that's where you can see that there could be a chance for error due to estimation. So something to confirm or emphasize here is that although we have this really good technology that's helping us with calculating something that's very intangible as AUC, at the end of the day, when it populates these regimens for you, us as pharmacists, we can still and are encouraged to still use our clinical judgment. When you are seeing all these regimens, kind of thinking about your patient and of course, ultimately making the best decisions for them. So there is that chance for error due to estimation. And so it's a mixture of using this very complex statistical method, as well as your own clinical judgment. So here at the time when I was a resident at St. B's, we were starting to be trained on the new Bayesian software, which was Insight RX. And here I wanted to just include like a visual walkthrough of what it looks like. So we have our test patient, Staph aureus, a 62-year-old male. And it's really nice because once you put in the information for your patient, it saves it for you. So when you come back into the system, you can revisit your patient and make adjustments as needed. So let's say you started them on this regimen, so 1 gram every 8 hours. It shows you, it's really nice. It shows you the predicted AUC, the trough, the possibility of the AUC being therapeutic, and then the possibility of toxicity. So let's say you obtained levels. So this was at the time, let's say we're transitioning from trough to AUC monitoring. We have a trough and the level is 14 and our serum creatinine is a little bit different than before. So what's interesting is that you can see, continuing on the same regimen, what your AUC and your trough and all of those elements are going to look like. And then you can start tweaking your dose. So here we can say, okay, it looks like we shouldn't continue on with that same dose. The probability of that AUC being pretty high, as you can see, is right there. And so tweaking it a little bit from 1 gram every 8 to every 12 will give you adjusted AUC numbers and troughs. So I just thought this was a nice visual representation of what that all looks like. So some final thoughts, putting it all together. There are potential exclusions to AUC guided dosing, and Kwan touched on this as well because they are also included in the guidelines and in the recommendation. We typically don't see AUC monitoring in your intermittent peritoneal hemodialysis, even your CRRT dialysis patients, just because of the factors that go into the dialysis, their stability, their renal function. There's a lot of things that you would have to monitor. So those patients, we would continue to dose based on levels and follow your institution's best practices for those patients. And again, alluding to the unstable renal function, even if your patient is not on hemodialysis, but they're not really having stable renal function, it wouldn't be advised to use AUC dosing in those patients as well. You're probably going to want to keep a closer eye on them, more frequent levels and dose adjustments that are more frequent. Also, as mentioned in the guidelines, when you have a patient who potentially is going to be on vancomycin for a short period of time, it's not really for a serious infection like surgical prophylaxis, skin and soft tissue, those patients were also excluded. There are many calculators available, like I mentioned before, in addition to those that are embedded in your electronic medical record. Some of them you can, I know a lot of pharmacists, even if their institution hasn't really switched to AUC monitoring, they like to go to ClinCalc and kind of see what the AUC is going to look like with the regimen that they've chosen. And because this is such a big shift in clinical practice, if your institution were to switch to AUC monitoring, whether Bayesian or the first step kinetics, all stakeholders involved should be educated on new dosing and this new monitoring method. So your pharmacists, your prescribers, your nurses, and your phlebotomists. So again, I just wanted to revisit our guidelines. Now we understand kind of where those initial guidelines came from and what the new guidelines mean and all the nitty-gritty details on that. So my key takeaways for you from this presentation today, troughs of 15 or less may be sufficient to achieve a therapeutic AUC to MIC ratio of 400 or more. That AUC to MIC range of 400 to 600 is recommended for achieving efficacy and avoiding toxicity. And switching to AUC monitoring does have the potential to reduce events of nephrotoxicity as well as frequent lab draws, which is also beneficial for our patients. Although AUC guided monitoring methods are not new, implementation in a clinical setting does require specialized software, especially if you're following the Bayesian method. And of course, successful implementation requires interprofessional coordination and education among everyone included in the patient's care process. Thank you all for joining us today. I believe I can open the floor to any questions, and I would love to hear about everyone's experiences in their institutions in terms of vancomycin monitoring and whether or not they've adapted this approach.
Wow, Very, very nice. Thank you so much, Lulua. It was an impressive introduction to AUC, overwhelming information, and a painful history of kinetics in classrooms.
Definitely.
Yes, thank you so much. Thank you, Kwan, as well for the great insights. And I will go through Shahama. I don't know if you would like to join us as well to the question and answer, but I will as well start with I will look into the question and answer box, and we'll start from there. And let's take a look. So there was a question about vancomycin monitoring in CRRT from Ali Abdullah. Is there any, can we use AUC? I would assume that was his question. Can we use AUC in CRRT? So I don't know if Lulua wants to answer or Kwan.
Yeah, I think kind of touching on that last point, with the guideline exclusions, most of your dialysis patients were excluded from AUC, especially with CRRT. You think about all those settings that you have to go through until the patient is at a stable level of filtration. I would imagine you would still want to check on levels more frequently until the patient is in that stable clearance range. But even then, I probably wouldn't switch to AUC. I haven't seen it being done in dialysis patients at all. I don't know if Kwan and yourself sitting, since you've seen it at St. B's after I left, I don't think we use them in that patient population.
No, I haven't seen it, not for CRRT or really any hemodialysis, even your intermittent. That's not when we would use like our Bayesian software, really.
Yes. Even in patients with AKI, or acute kidney injury patients, we don't usually use Bayesian as well. We would like to use it in patients who have stable, creatinine clearance, to have a better understanding of their AUC and better kinetics, basically, more reliable calculations. Since we're using more calculation base versus clinical base. Yes, awesome. So why AUC? So another question, I believe both of you did touch on this. It was mentioned. It's at Atik. He mentioned why AUC dosing used for vancomycin and what factors affects the AUC. I believe you guys did talk in depth, and Lulua, you mentioned a lot about AUC and why we use it. I don't know if you want to just, in a nutshell, if you want to reinforce the idea.
Yeah, what's nice about vancomycin, like we kind of talked about, is that the kinetics is not just time dependent. So it's not, you can look at it from a perspective of it always being above the MIC, but then also with the new data on it also being a concentration dependent antibiotic. So including both of those features, you can think of it as exposure dependent. So what's nice about, so because of those kinetic factors in vancomycin, you can use AUC monitoring. And that basically means you're trying to see the exposure of your organism to the drug within a 24-hour period. So it's more of an intangible concept of how much drug do you have within a 24-hour period. And so what's nice is that, again, based on the kinetic parameters of vancomycin, you can use that type of monitoring. What factors affect AUC? So I think we also talked about that with our patients, that you would probably use AUC monitoring in versus those that you don't. So again, you're going to be looking at your renal function, how serious the infection is.
You mentioned that most of the studies really, the concern was that we were underdosing patients with MRSA. And that's why we wanted to ensure that we were appropriately treating these patients. And that's why we wanted to test for or monitor AUC. So that's why basically we wanted to, the main concept is ensuring that we are treating appropriately patients who have serious infections, MRSA, not necessarily, assess, like just a cellulitis patient. We're very concerned about critically ill patients. Do you have any thoughts, Kwan?
I agree with that. And also to add on, also using AUC to try and prevent like the side effects of vancomycin, especially like nephrotoxicity, because as some of the trials have shown, you don't necessarily need to aim as high of those trots as what the previous guidelines had suggested. And then with this new AUC target of like 400 to 600, like in the infection specific, you can try and prevent some of those adverse effects without needing at such a high trough.
Yes, exactly. So there was a question about when should we then be using trough levels. So it's a shift in concept, right? And we're still trying to really change the mindset of, shifting from the trough to just looking at the AUC. So tell us about your experience, Kwan. Because I know my experience, I'll share it, but you go ahead.
Yes, it's definitely a change because I know when I was a student at other institutions, we were still using the trough concept. So getting a trough would be before the 4th dose when the person is at steady state. But something that is new and exciting is that with Bayesian software and using AUC guided dosing, you can get randoms. You can get your first random like 24 to 48 hours after the first dose, or even what I've been seeing, some pharmacists like to get a level, like check a level the next day at 6 a.m. with morning labs. Now something to like warn or like be aware of is that if they are getting a random level and you're just looking at that number, it might look really high or really low, but you just need to take into account when that level was drawn, like how many hours post-dose and how close it is to the next one. So just something to keep in mind.
Yes. So from practicality, like what I do like about it really is that we can draw with morning labs. So you are using less blood samples for patients, so less poking, more convenience for the patients, for the nurses, for the staff. So it's very convenient, and you don't need more than one sample. So one concentration is enough for at least for our program, because some other programs may need 2 concentrations, so they may need 2 samples. But for our calculator that we're using, we're doing only 1 sample. So that's pretty exciting. I think it's very convenient for the patient, and for the whole clinical staff. I think it's a good thing. Lulu, you have other thoughts to add in this concept?
No, I think that it all ties into what we were talking about. Like, it's really nice to see when we talk about like articles and the theoretical part of it, and then in practice, how much it does truly change. When we're talking about less lab draws, less nephrotoxicity, all those things, like convenience and efficiency for pharmacists and everyone involved. So it's really nice to see like both sides of the topics we talk about.
Yes, exactly. One thing too, that it did need some education as well for nurses and some physicians to recognize that when you're seeing that high of a level in the morning, sometimes that level could be like 3 hours or 4 hours after the dose.
Exactly.
Sometimes everybody freaks out. So we really needed to ensure that within our notes, or we are educating everyone that we are using a different concept. Please don't discontinue vancomycin. This is not the trough. It's a random, so it's a big difference. So there's a lot of education points when you start to practice different things that you really don't pay attention to, simple things. But I've seen some doctors discontinuing vancomycin when they see the level. Oh my God, it's 40. Like, no, it's not the trough, please. So yes. So another question was like, can we use AUC in pediatric patients?
Yes, we can. And I know at Mercy, because we do have the Children's Hospital, I believe it's a different software though. Is that correct? I think
we can, right, Kwan? We're using Insight.
Yes, I believe you can use Insight for pediatric dosing. I don't have much experience with that, but I do know the system that we use is capable of using a pediatric patient.
Mm-hmm.
Right. It would just be like the population kinetics, of course, that it's based upon is different than your adults, but yeah.
Yes.
You can use it.
Yeah, and it's still the same. It's the 400. You're still shooting for the same range, AUC 400 to 600.
Mm-hmm.
Yeah. And there is an interesting question here from Raad Al-Sabri. Do we need to validate the software prior to implementation to the population in the Middle East? It may have potential risk of over or underestimation of drug concentration. So there is this discussion, right, that the different software or the Bayesian has population-specific data.
Correct.
Based on that, we basically have like a broad understanding that if your patient would fit or not.
Yeah.
And this was tested in the US. So this is, yes, but we don't know if any was tested in the Middle East. So that's a very interesting question. What do you guys think?
Yeah, I do think that's an interesting question. Unfortunately, I probably wouldn't be able to comment too intelligently on that because I'm not sure of how different it would be. It would probably be different just because, like we said, the software is always based on different population kinetics. So the way that each software is built, or even calculators are built, are different based on the population that you've studied. And so I would imagine that you would have to study a population more similar to your Middle Eastern patient in that region to apply it. Again, I'm not sure 100%, but that's what I would imagine based on the information that we were talking about.
Yeah, exactly. I think so. I would assume, but that's a very good question that we can shoot inside our racks. We're not advertising for the program, just an FYI. We're just giving an example because I bet there are other examples out there. Absolutely. That is, other softwares, like many, and that being used. But I think this is an important question for any hospital anywhere in the world to ask if it fits their population or not. Absolutely. It could be like in Asia, Africa, anywhere. So that's a very good question. They're mentioning, can we all share an Excel sheet for AUC? Unfortunately, we don't have it.
No, I'm not sure if one of the links I included, I would have to check. Can't remember if it was the Excel sheet or
so let's see here. In some hospitals, let me take a look. So there was a question about, I don't know if you guys have seen this. Yahya Al-Khawli, he said, can you use AUC MIC for pregnant women?
That's a good question.
Yeah, that's a good question. I'm not sure on that. I don't think I've encountered that, or maybe I haven't noticed when dosing a patient if they were pregnant or not. I'm not sure what kinetics would be different that might affect the ability to use or not be able to use for pregnant women. But that's something that I would need to look into.
Yeah, I don't know, in the studies that we have looked at, or you have looked at, Lulwa, did you see that they maybe have any comments on pregnant pregnant women at all? Did they have anything about them in their studies?
The 3 studies that I talked about, most of the baseline characteristics were pretty similar, and at least from what I've noticed, there was no mention of pregnant women. But when I think of like vancomycin dosing, at least at the time when I was a resident, we would still follow your trough. Before, AUC was introduced at V's, like we would still follow the trough dosing. You would still follow your nomogram for the institution, of course, using your clinical judgment. So I don't imagine there being too much of a difference in kinetics. So as long as it can be safely used in your patient who has stable renal function, like we said, all those other factors, I'm not sure how much pregnancy adds to that. If that's even a consideration, or if it would probably be safe in both, because it's still like a monitoring.
Exactly. So it's basically you're still monitoring levels,
right?
And you're still monitoring kidney function,
right,
and clinical response.
Exactly.
Yes. Hi, Shahama. We still have time for questions, or?
Yeah, we still have 10 minutes.
Okay. Okay, so they mentioned about loading dose. If we use loading dose 20 to 25 milligram per kilogram, should we still wait for 3 doses before taking a trough level?
So with like if you are using Bayesian dosing, you don't need to wait the 3 doses. You could even get a level like 24 to 48 hours after that loading dose. If maybe you have a critically ill patient or someone with a renal function that you're not really sure how they're going to respond, you can order a dose, say for the next day, just to get a first initial level. And then if you can wait until they reach like steady state if you want to get like a typical true trough once they reach that steady state after like that before that 4th dose.
And I do want to give an example just from the perspective of the program. When Lulua mentioned that the AUC could be above 400, but the trough could be less than 15. So sometimes if I'm treating, for example, patients with endocarditis or meningitis or pneumonia, where I really want to, like initially before looking at AUC, I used to try to shoot for a trough that's closer to, the higher the better, as long as I'm not hurting the kidney. But right now, as long as it is above 400, sometimes looking at the calculation, when it calculates trough at steady states for me, the trough looks sometimes below 15. So with the graphing and the plotting that you showed us, Lulua, it did prove to us that not necessarily that you're actually causing more nephrotoxicity, and then more so than, it's not necessarily that you're actually, and the AUC is actually above 600.
Right.
So you're causing more harm than good, basically. And then let's take a look. So they're asking about online calculator. Unfortunately, I don't think from practical, and we like that each institution will need to approve the clinical pharmacist calculators. At the end of the day, if you guys all agree with me, you would all have to look at the patients as like patients in general. If they're critically ill, we have to look at as well at if they also have other nephrotoxic agents. We have to look at the patient clinically, in addition of using the calculator as well. It can guide us and it can help us, but it cannot replace our clinical judgment. So regardless of what calculators the pharmacist wants to use, it needs to be approved by their site, and it cannot replace their clinical judgment, I would say. You guys agree?
100%.
Yes.
All right. Shahama, you have any? I think we do have other, so they're very similar talking about AUC and MIC. I believe you guys have already answered most of the concepts, but if anybody have any questions, they can email us and we're more than happy to share further thoughts. Thank you both for your presence with me. It was a pleasure for me to have you.
Thank you for the invitation.
Thank you so much.
It's good to be here.
Thank you.
Thank you. Thank you, my dear Shireen, for your amazing efforts for moderating this fantastic event and interesting question and answer period. And for the fabulous speakers, Dr. Lulwa and Dr. Kiwan, for sharing their valuable time and expertise tonight with us. It was truly insightful by all meanings. And I strongly believe everyone in this in the audience is looking forward for more profoundly important topics like this one in the future. Please note that the certificates of attendance will be issued within 7 days, and the session recording will be uploaded to the website of IVPN Library within 15 days. And with this, we come to the end of this IVPN Journal Club session for today. I would like deeply to thank each one of you for your active making this session interactable and fruitful as possible. Stay tuned for the upcoming new activities with IVPN Journal Club Listserv. Yet part of the IVPN network, please visit our website, ivpnnetwork.com, and register to our listserv. Thank you for your trust in advising and expertise. Have a good evening and rest of the day. Goodbye.
Bye.
Thank you.
Thank you.